Hello friends. Thanks Nishant for having me for this talk in for Salem Group. The topic I was asked to talk was on COPD ventilation. How do we do ventilation in COPD in patients who are on NIV and in patients who are intubated and mechanically ventilated? So the first half of my talk, I'll be talking on NIV and its role in COPD. And after that, I'll be talking a bit on invasive ventilation. So we'll see maybe over next 20 to 30 minutes, I should be able to cover this. So the whole science of NIV, if you look at, it came way back, maybe around 100 years back in 1936. So this was the first study that came out in Lancet talking about the role of NIV. And as you see, these were the early sort of equipment that was used to deliver NIV. So what do we understand by NIV? Basically, it's a delivery of the same mechanical ventilation principles without putting in the ET tube through the throat. So that's all it means. So it is, but all the other parameters that we tend to use pretty much would subscribe to the science of parameters we set in the invasive ventilation. There are few little differences with that. So, but without endotracheal tube, the ventilatory support that we provide is called as non-invasive ventilation. So before we dwell into how we use the NIV, it is very imperative that every trainee listening to this understand. So what are the effects of NIV in a patient? So this is very, very important. So just put it in a pictorial way. So when we provide NIV, it has a multimodal effect on a patient. So the most important thing is it improves alveolar ventilation and it helps in recruitment of alveoli in alveoli which may have been collapsed or which may have been pathological due to pneumonia or pulmonary so on and so forth. And it reduces the work of breathing. So in COPD, I'm sure everyone would agree that there'll be increased work of breathing. NIV helps in reducing the work of breathing, and COPD, they have exacerbation due to pneumonia, where recruitment of alveoli becomes important. It improves alveolar ventilation. Most importantly, many a time COPDs will have concomitant cardiac issues and they may have LV dysfunction, or many of them would have pulmonary with RV dysfunction. It does significantly help in reducing the LV afterload. So we all clearly understand that ventilation and any sort of ventilation has a favorable effect on reducing the load on the LV. So it does reduce the LV afterload and it helps in stabilization of the muscles also in someone who has reduced minute ventilation. So many of the COPD patients would have muscle atrophy, which may lead to chest wall muscle weakness or any other reason if COPD has any other concomitant neuromuscular issues where muscle ventilation is reduced or minute ventilation is reduced. It helps in improving that as well and stabilizes the chest wall as well. So when we talk about physiology of NIV, there are certain pressures that every trainee needs to understand. So the whole effort that respiratory muscle system puts in place is called PMUS. That's the pressure that is needed for optimal functioning of the whole respiratory apparatus. And this PMUS is dependent on few pressures. So there is this elastic pressure. So, and there is resistive pressure. Then there is this baseline pressure within the alveoli, which is called threshold pressure. So for a good ventilation to happen, so these pressures have to overcome. So any ventilation, one has to overcome the elastic pressures that is present in the lung due to elastic recoil, and there is a resistive pressure, and there is this baseline pressure, which is called threshold pressure. These pressures have to be overcome for effective ventilation to happen. And that's why we call the whole effectiveness or optimal functioning of the respiratory system is this combination of these pressures minus airway opening pressure. So these pressures have to be overcome to open the alveoli and for effective ventilation to happen. So simply put, so the total pressure of the respiratory apparatus with the airway opening pressure is dependent on elastance or the elastic recoil properties of the lung. It is dependent on the volume of the lung, so the amount of tidal volume that is present in the lung. It is dependent on the resistance. It is dependent on the inspiratory flow and the baseline pressure, which is the intrinsic PEEP that is present. So these are the key elements which determine the optimal ventilation of the lung in a patient. So these pressures have to be overcome effectively for effective ventilation to happen. So any pressure settings that we do we should factor in the elastance that is present, and any sort of a pressures that we send should factor in the amount of tidal volume that is delivered. So any of the settings that we put in should overcome the resistance in the lungs. And these pressures are determined on the inspiratory flow of the gases and the intrinsic PEEP that may be prevailing. So this is a very important equation. Physiologically, we should be cognizant of these pressures, which have to be overcome for effective ventilation to happen. So when we talk about non-invasive ventilation, there are a lot of terminologies we use. We use CPAP, we use pressure support, we use BiPAP, and we use NIPPV. So they're all interchangeably used, but the physiological concept, because these nomenclatures tend to change with the type of instruments that we use, but fundamentally, the the core essence of the science that remains is those pressures that need to be tackled for effective ventilation to happen. We'll just try to delineate as to how we understand this. So as I said, any NIV you give, it reduces afterload. So when there is effective recruitment of the alveoli that happens, so we understand with NIV, there is a good recruitment of alveoli, and this recruitment of the alveoli helps in reducing the elastic pressure. So it overcomes the elastic pressure, and the intrinsic PEEP or the PEEP you provide in the ventilation helps to overcome the threshold pressure, which I mentioned. And and all in all, these by overcoming these pressures, it helps to reduce the shunt fraction. So shunt is where your alveoli is not participating in the gas exchange. So it reduces the shunt fraction by recruitment, and by providing PEEP, it overcomes the elastic pressure and the threshold pressure and helps in effectively circumventing the shunt issues. So this is how the NIV helps in optimizing the ventilation. So what do we understand? So this is in with regards to the pressure support or only the CPAP that you give. But in NIV, in COPD, we add inspiratory positive airway pressure along with the CPAP or the pressure support ventilation. So we add IPAP. So the inspiratory pressure, what we add, what does it do? It increases the tidal volume. And this increase in the tidal volume in the alveoli is needed to reduce your CO2. So we all understand, all the listeners here would understand that in COPD, our whole effort is to remove this carbon dioxide because there is difficulty in getting this carbon dioxide out in COPD. That's why they have CO2 retention. By providing inspiratory positive airway pressure, there's increase in the alveolar tidal volume, which helps in reducing the CO2. That's why we've added IPAP. That's why it's called bi-level positive airway pressure. And this is also shown to improve the surfactant production by the alveolar pneumocytes. And by giving IPAP, it will reduce this elastic pressure and resistive pressure comes down. Because you saw in the previous slide, the pressure support or the CPAP that you give tends to overcome the resistive pressure and the threshold pressure. By adding IPAP, it reduces the elastic pressure and the resistive pressure and increases the alveolar tidal volume and reduces the carbon dioxide. All in all, it reduces your whole respiratory effort or the respiratory apparatus pressure it reduces and reduces the work of breathing. So this in principle is how this NIV is beneficial in COPD. So when we say BiPAP, BiPAP is we add inspiratory positive airway pressure plus expiratory positive airway pressure, which you can also call CPAP. You can also call it as pressure support plus EPAP or plus CPAP. So we add inspiratory positive airway pressure in addition to CPAP or expiratory positive airway pressure. That's why we call as bi-level positive airway pressure. So what is the physiological rationale or benefit of using NIV in respiratory failure? As I said, in addition to all those pressures that it overcomes the elastic pressure, it overcomes the resistive pressure, it overcomes the threshold pressure, and it offers PEEP, it reduces the shunt fraction. So by doing all this, it significantly reduces the shunt fraction. As you see, shunt fraction is this part of the alveoli is not participating in the gas exchange. So by providing NIV, it tends to circumvent this alveoli which is not participating by recruiting the alveoli, and it improves the oxygenation. And NIV also helps to improve ventilation perfusion mismatch. Here, the alveoli are getting ventilated, but there is a compromise in the perfusion because of compression of the vessels due to emphysematous chest. So there is physiological dead space that increases. So this also tends to be optimized with NIV. And diffusion impairment is another cause of respiratory failure where effective exchange of gases are not happening. And there are other issues where you may have thromboembolism in the pulmonary circulation, which also leads to ventilator and perfusion mismatch. So just to show you pictorially, before NIV, you would see the alveoli would be collapsed. So post NIV, you will have these alveoli which are well recruited, well optimized, and you see good ventilation perfusion matching happens. So there is improvement in the ventilation perfusion sort of a ratio that happens. And all in all, it improves the oxygenation. And it is also important to understand that NIV is helpful in hypoventilation disorders. And it is also, as I said, it augments the functioning of your respiratory muscles in situations where your minute ventilation is down due to neuromuscular weakness. And many of the end-stage COPDs would have sort of a muscle atrophy and chest muscle wasting. And there also it helps to improve minute ventilation. With NIV, it tends to improve the minute ventilation by accentuating the functioning of the respiratory muscles. So that is in sort of a quick sort of a overview on physiological rationale as to how NIV helps and what are the pressures that it overcomes to improve oxygenation is what we saw. So indications for BiPAP is predominantly in asthma, COPD, and sometimes even in acute respiratory failure. So there are certain contraindications for NIV. I've just put a cartoon. So any patients who has inability to clear the secretions, who has a poor sort of a cough reflex, or who has upper airway obstruction. So these are the situations where NIV cannot be used because they should have good airway reflexes. They should be able to protect the airway. Or severe acute asthma where there is severe bronchospasm, NIV is not something that will be useful. And in pneumothorax, it can worsen. So these are some of the where the GCS conscious level is very low. It's a relative sort of a contraindication because they won't be able to protect the airway. Or in someone who is very hemodynamically unstable, NIV can sort of offset the stability. So these are some of the accepted sort of a contraindications for NIV. So what are the complications of non-invasive ventilation in COPD? So if someone has a COPD with a head injury, it can worsen the intracranial pressure, or someone COPD with a stroke or any neurological conditions, it can increase the ICP. And someone with glaucoma, one has to be cautious. It can increase the intraocular pressure. And one knows that when someone is on NIV, there will be a lot of nasal congestion, dryness of the mouth. So there would be discomfort or intolerance due to claustrophobia, and where there is sometimes there can be a risk of aspiration. Because it's a positive pressure ventilation, if someone is low on the volume status, it can cause hemodynamic instability with hypotension. So there can be gastric distension. So these are some of the complications one need to keep in mind when you're using NIV in a COPD patient or for any patient for that matter. So we'll just move to what are the equipments that are needed when you're using NIV. So one thing is in ICU, when we use NIV, it is the ICU ventilators. We do not use home CPAP or home BiPAP for patients in ICU because in ICU, it is imperative that we understand that these patients are sicker. They may have a concomitant pathology. It could be pneumonia, it could be pulmonary edema. So it is expected that we use a proper ICU ventilator with a walled oxygen. So one of the prerequisites is they should have a walled oxygen to deliver high flow gas flows. And mask fit is something that is very important. So whenever you are using an NIV mask, it is important to make sure there is no leakage of the mask that you have put in. And generally, NIV, you can have a single limb or a two limb. Like when I say it is the ICU sort of a ventilator we use, it is expected that we have a two-limbed circuit. If for some reason you are using a one-limbed circuit, one has to put in a PEEP valve because with the resistor for the flow or threshold resistor. And this PEEP valve helps you to provide adequate PEEP in patients. But if it is a two-limbed circuit, then you would obviously set the PEEP on the ventilator that patient is connected to. And it is desirable that the length of the tubes that are used in COPD are shorter length to reduce the sort of the resistance when you are ventilating. And it is desirable the diameter of the tubes is wider, and there should be adjustment for variable FI2. So all these are taken as something that will be present when you're using a standard ICU ventilator to provide NIV, because you will have a PEEP adjustment on the machine and you would have ability to tweak the FiO2 on the machine, but keep an eye on the length and the diameter of the tube. But these are all of standard length, but ensure that they're not very long. Shorter the tubes, better it is. And the NIV machine is meant to have flow and pressure sensors to identify and to sort of follow up on these pressure and flows that are set for these patients. So these sensors, because many a times you would see that sensors may be dysfunctional, then you wouldn't know what are the key target flows and pressures that you need to set on the machine. And another important thing, as I said, when someone is put on a NIV, there is a lot of dryness of the mouth, and this can lead to sequestration of all the secretions. So good humidification is also something that is needed, and it is very often you would see that humidification is sort of underwhelmed or not given importance. So it is important that when NIV is being provided, you need to have a good humidification process when this is provided. And any NIV circuit should have ability to connect the nebulizer. So you have these jet nebulizers which should be connected. So the limbs that you are using for providing NIV should have ability to connect this jet nebulizer or vibrating mesh nebulizer, aeronebulizer, because in our ICU we use vibrating mesh nebulizer. So it should have ability to connect to these vibrating mesh nebulizers to provide nebulization, because COPD patients would need ongoing nebulization. And these machines should have backup battery and backup apnea sort of a tools. So when we are dealing with a patient with COPD and exacerbation, so these patients, our aim is to obviously improve the pH, because these patients will have acidemia due to high CO2, and our aim is to reduce the CO2 in these patients, and our aim is to reduce the shortness of breath or the work of breathing. And all these targets have to be carefully monitored every hour, and a call has to be taken whether NIV is helping the patient and alleviating their symptoms. And it is shown that early usage of NIV in COPD reduces the length of stay, and it does reduce the mortality and does reduce the intubation rates if used early and effectively. And the success rate of NIV in COPD is very good. It's put at 80 to 85%. So what is most important is the use of NIV in COPD. This is very important, is a quality indicator. And every patient who comes to ICU with COPD exacerbation should be given a trial of extubation. As you see, 95% of the COPD exacerbation should get NIV trial, which is a quality indicator. If you are not providing NIV and jumping to intubate without a trial of NIV is a breach in the quality indicator. This is just an audit that we did in our hospital to see how effectively we are using NIV. And this was the percentage of the cases that we were using NIV. 40% of the respiratory cases we had used NIV, and around close to 30% we used in cardiology patients, so on and so forth. So what are the ventilatory settings that is expected in COPD? So the mode we put on a spontaneous or timed mode. The IPAP we generally put at 12 to 15 centimeter of water, and EPAP of 4 to 5 centimeters. So we keep a differential of around 7 to 8 in IPAP and EPAP when we are setting these pressures between IPAP and EPAP. So trigger, we put at a maximum sensitivity in patients who is very tachypnic, who is very conscious. We put the trigger at a high sensitivity. If someone who is often dead, who is not taking enough breath, we put the sensitivity little much lower, because you need it to be triggered for any breath that they initiate. And the backup rate we put up around 15 breaths per minute. So these are the initial setting, and backup inspiratory expiratory ratio we put at 1:3. So these are some of the basic sort of settings that we put on the ventilator. So when we are setting it up, so make sure that there is no contraindication when you are connecting the patient to NIV. And before NIV, patient should be on non-rebreather mask so that they are adequately oxygenated. And most importantly, patients have to be explained about the NIV as to what we are doing with the patient, and they had, because they'll be very agitated and they'll be very apprehensive. They wouldn't understand because suddenly you are connecting a mask where they cannot speak, and they would be very apprehensive. And so the compliance of the patient to the machine becomes very important. So constant reassurance to the patient is pivotal in the success of NIV. And as I already mentioned, the correct mask fit is something that is very important to ensure effective ventilation when you are giving NIV, to ensure there's not much leakage of the gases that are happening. So most importantly, as I said, when someone is connected to NIV, it is important to see whether patient is responding to the NIV, whether the parameters are getting better. It is important once you put them on NIV, they need to be more diligently and vigilantly watched, monitored, observed, and regular assessment has to be done. So there are various other masks like nasal masks, there are full masks, and there is helmet mask. And I'm sure many of the listeners would have used many of these. In COVID, especially this helmet mask became a little more popular. So how do we monitor the response? Once we connect the patient to NIV, one has to see if the tachycardia which the patient would be having due to exacerbation of COPD is settling down with reduction in the heart rate, and whether the oxygenation is improving, and he or she would be very hypertensive when there is exacerbation. So whether the blood pressure is settling down and the tachypnea is settling down. So these are some of the favorable parameters which would give you comfort that patient is responding to the NIV that you are given. And look for the accessory muscles of breathing, whether these accessory muscles of breathing are settled down. And the patient may have been very drowsy because of high CO2. Look for improvement in the mental status and look for the coordinated muscle movements. Look whether patient is getting more comfortable, whether the diaphoresis is settling down, whether shortness of breath is settled down. And very important to keep monitoring arterial blood gas at least every 4 to 6 hourly to see if the pH is getting better, if carbon dioxide is coming down, oxygen is improving, so on and so forth. So these are so the quintessence of NIV is to see whether the parameters trends are getting more favorable after the initiation of NIV, and that is correlating to the clinical improvement of the patient. So treatment failure is you have connected the ventilator, you have put the settings, IPAP, EPAP, you have made sure you are giving good humidification and you are monitoring. But if patient is getting more obtended and is getting more acidemic and CO2 is rising despite whatever good parameters you have put in, and there is worsening or non-improving ABG, or when there is intolerance or failure to coordinate because patient may be very restless and not complying in keeping the mask and not settling with sedation. So these are failure where you have to call it as a failure of NIV and move on to intubation and mechanical ventilation. So intolerance is one of the key things that many a times would be a reason why sometimes NIV fails and one has to get intubated. Or there is no improvement in the oxygenation, or he's getting more and more hemodynamically unstable, or when there are cardiac sort of a dysrhythmias that are setting in. So this becomes a very difficult situation to manage with NIV, and many a times we may have to move towards intubation. So for the clinical improvement, one has to look for keeping the tachypnea settled, tachycardia settled, and pH is improving, and saturation is more than 90% on FiO2 of 40%, and so on and so forth. So at that point of time, you can think of weaning the NIV. So just to look at the evidence, so there are multiple robust studies which have shown that NIV is significantly beneficial for pulmonary edema. There are around 23 randomized controlled trials and 3 meta-analyses which show that NIV really helps. In COPD, which is of interest in today's discussion, there are 14 randomized controlled trials which have shown significant benefit with the usage of NIV. And there are 8 randomized controlled trials in hypoxemic respiratory failure. In immunocompromised, there are 3 randomized controlled trials and multiple observational studies. So for COPD, the use of NIV is been given grade 1A recommendation. And even in cardiogenic pulmonary edema, it is given grade 1A, so which is a strong recommendation with good scientific evidence substantiating the usage of NIV. For hypoxemic respiratory failure, it is grade 2B recommendation. So very briefly, I'll look into just very briefly on 1 or 2 studies. In COPD, these are the studies which are shown BiPAP is better than CPAP or pressure support with regards to outcomes, and BiPAP is shown to be superior in improving gas exchange and in reducing the work of breathing in patients with COPD. So, and these are the studies which have shown that in COPD, the use of non-invasive ventilation significantly reduces the mortality, significantly reduces the risk of infections, secondary infections, and significantly reduces the risk of intubation rates by 20% with the usage of NIV in COPD as compared to mechanical ventilation. And this is a big meta-analysis which came some time ago in UK, which is a meta-analysis of 14 randomized controlled trials, where they compared NIV with compared to the other group. It did not get NIV, and they showed the mortality was significantly less, treatment failure was significantly less, intubation rate was significantly less, and hospital length of stay also was shorter. So because of all these robust studies, around 14 randomized controlled trials that have shown very conclusively that COPD, the trial of NIV has to be given. It is included as quality benchmark, and it is a quality indicator for every intensivist that a trial of NIV has to be given before you resort to intubating and mechanically ventilating. And this is the most recent sort of a review article that came, non-invasive support for adults with acute respiratory failure, which came in NEJM in 2022, where if you see, before invasive mechanical ventilation for COPD, a trial of NIV has to be given. And even to that effect, there is a strong recommendation that even after extubating the patient of COPD, one can give a trial of non-invasive ventilation, extubating to NIV to prevent reintubation in patient at risk for extubation failure, as shown is something that is very important that came out of this article. So all in all, NIV is the way to go. Even before intubation, give a trial. Post extubation, to prevent failure of extubation, they can be bridged with NIV support and then weaned off later is the way to go. So the summary is NIV is proven to have sound physiological rationale. When I say sound physiological rationale, it is those multimodal effects. It recruits the alveoli, it overcomes the resistive pressure, it overcomes the elastic pressure, it overcomes the threshold pressure, and it reduces the respiratory effort significantly, and it reduces the shunt fraction, improves the ventilation perfusion mass match. So all these are the sound physiological rationale as to why NIV is significantly beneficial. It is shown a proven safety in saving lives in last 1 century, and it has shown to influence favorable outcome in these conditions: pulmonary edema, COPD, hypoxemic respiratory failure. And there are more than 55 good quality practice changing trials to substantiate usage of NIV. And we have seen NIV was a life savior in COVID-19 pandemic. So that's about the role of NIV from the practical standpoint for all the clinicians who may be hearing to this as to its role in COPD. Now we'll go to patients who are intubated. So where NIV has failed, then COPD patients get intubated, mechanically ventilated. So what is the role of, so basically when someone is intubated and mechanically ventilated, what does the ventilator do? It pushes the oxygen in and gets the carbon dioxide out. We have clearly understood in COPD, the basic problem that patient has is in the ability to get this carbon dioxide out. And we need to understand this very important equation in any patient who's on a ventilator. So the airway pressure is dependent on flow of gases through the airways and the resistance the airways have. And it is dependent on the volume divided by compliance, which determines your alveolar function with the PEEP, because every alveoli is open because of the baseline pressure, which we call as PEEP. So your whole airway pressure is equal to flow into resistance plus volume divided by compliance plus PEEP. And this equation is something which should be dinned into everyone's mind, is what determines the whole science of mechanical ventilation, because your whole gas flows within the lungs and that come out of the lungs are determined by these sort of a parameters or variables. So airway pressure is dependent on the flow, and this flow is something that we can set on a ventilator. And resistance is something that is very intrinsic to the lung, and resistance is something we cannot set. And resistance is determined by the pathology, because we know in COPD resistance increases, and this is something which is determined by how your lungs are. And the volume is something that we can set on the ventilator, and the PEEP is something that we can set on ventilator. So there are two things we cannot set. Resistance is the intrinsic nature of the lung, and the compliance also is the intrinsic. because if you have a pneumonia, your compliance would have come down. In COPD, compliance is usually normal or high if there is no pathology. So in COPD, as I said, the whole problem is for the carbon dioxide to come out, and there is difficulty in for the carbon dioxide to come out, and many a times there is reduced time that is available for this carbon dioxide to come out in these patients. So what happens, because they are breathing so fast and there is reduced time that is available for this carbon dioxide to come out, there is more of trapping of this carbon dioxide within this alveoli. Because it gets trapped, so the alveoli gets bloated, which we call as dynamic hyperinflation. As the name sounds, the alveoli gets bloated because there is not enough time for this carbon dioxide to come out, and because the elastic recoil properties of this airway is lost. Because there is bloating, there is the pressure within this alveoli increases, which we call as intrinsic PEEP. So the reasons for this is there is increase in the inspiratory time. They take enough breath with good timing, but the expiratory time is low. There is inadequate time that is available for the carbon dioxide to come out. And these patients are tachypneic because they have high respiratory rate. Because your respiratory rate is high, your expiratory time gets shortened. Your absolute expiratory time gets shortened. And the larger tidal volume also accentuate this bloating of this alveoli. So all in all, in this COPD patients, when you connect them to ventilator, they they tend to have hemodynamic compromise or blood pressure tends to come down. Why does this happen? Because in patients where already your alveoli are bloating and the pressure in the chest is so high, so your venous return decreases. So when there is a hemodynamic instability, it is desirable that you disconnect the patient from the ventilator and allow the gases to come out, because your whole venous return reduces because of the increase in the intrathoracic pressure, which is causing the hypotension. And if you are facing this situation for a very brief period of time, you can discontinue the patient from the ventilator to reduce this dynamic hyperinflation. Okay. So the problems that in COPD that we face that needs to be circumvented is there is increased airway resistance, and we saw that there is reduced time to get this carbon dioxide out, which leads to dynamic hyperinflation. So this is one problem which we need to address in any patient of COPD who is mechanically ventilated, that we need to improve the time. So because there is reduced time for this carbon dioxide to come out, we have to increase the time so that enough time is given for this carbon dioxide to come out. And we have to address this increased airway resistance by bronchodilation. And we have to circumvent this respiratory acidosis. And then the other problem we need to circumvent is to alleviate or mitigate or minimize the risk of them developing pneumothorax because of the increasing in the pressures. So what are the reasonable initial settings that we could think of in COPD? The reasonable initial setting is assist control mode ventilation or controlled mode ventilation is desirable. Tidal volume has to be lower because we saw in the previous slides that increase in the tidal volume is something which will worsen your dynamic hyperinflation. And initially you can put them on 100%, and respiratory rate has to be kept at a lower respiratory rate, because many of the clinicians would think if CO2 is building up, we'll just increase the respiratory rate. Increase in the respiratory rate will worsen the dynamic hyper, because we saw when you increase the respiratory rate, there's not enough time that is given for the carbon dioxide to come out, because tachypnea is not good. You have to reduce the respiratory rate. And the key thing is to increase the IE ratio. So expiratory time has to be increased because they have enough time for this carbon dioxide to come out. And PEEP, you can keep it initially less. I think 5 is reasonable, or it can reduce it further. So there is a concept of the intrinsic, the PEEP that we need to keep to circumvent the intrinsic PEEP. So two-thirds of the intrinsic PEEP, up to two-thirds of the intrinsic PEEP is sort of allowed, but not more than that, because that can worsen the dynamic hyperinflation. And the inspiratory rise time is around 5. So the rise time is the time that is set for the set goals to be achieved, or for the set pressures or the flows to achieve. So when I said there is increase in the respiratory rate, as you say, when there is a tachypneic, your whole expiratory time gets shortened. But on the same note, if you have a longer expiratory time, you have enough time for this expiration to happen and reach the baseline. So it is very important that we reduce the respiratory, because if you keep the respiratory rate high, your expiratory time also comes down, your carbon dioxide builds up, your intrinsic PEEP builds up. Okay. So that is something that one needs to pay attention. So what we need to understand is, if you have a longer inspiratory time, it improves oxygenation. It improves oxygenation by improving the mean airway pressure and by redistribution. And longer inspiratory time lowers the peak airway pressure by increasing the time for the tidal volumes to be delivered. So we don't want this. So if you put a longer inspiratory time, basically there is more in the tidal volume which is not needed. So what we need is shorter inspiratory time and longer expiratory time, because this longer expiratory time will allow time for the carbon dioxide to be expelled, and it lowers the risk of dynamic hyperinflation or intrinsic peak. And your longer expiratory time will also mitigate your hemodynamic instability that will happen because of increase in the dynamic hyperinflation that tends to set in. And as I said, most of the trainees would know when we call air trapping, you have to look at this is the flow time scalars you need to look at. So because there is inadequate time for the expiration to be completed, there is this air trapping which we call as auto peep that tends to set in. So higher tidal volume is bad for COPD. That's why we keep lower tidal volume and we lower the respiratory rate, and we tend to keep the peep low, and we tend to increase the expiratory time. So higher tidal volume, higher respiratory rate, and shorter expiratory time is what will lead to worsening of intrinsic PEEP or dynamic hyperinflation. So the treatment is, we need to lower the tidal volume, we need to reduce the respiratory rate, and we need to increase the expiratory time, because the whole problem in COPD is there's not enough time for the carbon dioxide to come out. We need to provide more time for this carbon dioxide to come out to prevent this dynamic hyperinflation. And this is the flow volume loop where you see during expiration, it is not touching the baseline, which is the auto peak. So the summary is, for inpatients who are mechanically ventilated, remember your whole principle of ventilation is governed by flow of gases, which you can set in a ventilator. Resistance is what is intrinsically determined by the nature of the lung. Volume is something you can decide. As I said, more tidal volume, more dynamic hyperinflation in COPD exacerbation. So that is something you can set. Compliance is determined by the intrinsic nature of the lung, and PEEP is something that you can set. And the determinants of ventilation, which is to improve oxygenation, reduce the carbon dioxide, and this can be achieved by tweaking your inspiratory time. You want more oxygen, you have to increase inspiratory time. You want to reduce carbon dioxide, you have to reduce inspiratory time and increase the expiratory time. And volumes have to be adjusted accordingly, and PEEP has to be adjusted accordingly. And always look for intrinsic PEEP should be less than 10. So look at the flow time pattern and look at the expiration, whether it is touching the baseline. If it is not touching, then there is intrinsic PEEP, and you have to address it by tweaking all the variables, and this can lead to severe dysynchrony, and that is something that one needs to keep in mind. All in all, if you are not addressing these dynamic hyperinflation and intrinsic PEEP, it will stress the lung. It will put enormous stress to the lung, and the work of breathing increases, and the respiratory effort also significantly increases. So our whole effort is to reduce the stress on the lung and reduce the respiratory effort by tweaking all these variables. So that is in brief about the practical approach as to how we can optimize ventilation in COPD. So thank you one and all. So you can visit my website www.drpradeeprangappa.com to rehear to this lecture. So this is more of a basic tenets of management I have covered. So there's a lot of physiological components into it, but what I what is really elucidated is more from the practical standpoint, which should help clinicians to manage COPDs in a safe way. So thank you, Vandal.